KEYNOTE-042 was a randomized trial looking at pembrolizumab monotherapy in a select patient population, and it has influenced care. This was a large study of over 1,200 patients with advanced non-small cell lung cancer, excluding patients with sensitizing EGFR mutations or ALK fusions. All patients did have PD-L1 expression, defined in that study by at least 1% of cells positive using the DACO22C3 clone. They're randomized to pembrolizumab monotherapy or histology-specific chemotherapy. And what we saw was an improvement in overall survival with this approach, leading to its FDA approval for patients with PD-L1 of 1% or greater. But this was driven, as expected, by the PD-L1 high cohort that we saw in KEYNOTE-24. The population of interest was that PD-L1 low. Are we really providing a better option for more patients? And if we really analyze patients with PD-L1 expression between 1 to 49%, where the use of pembrolizumab wasn't clear prior to this trial, there was not a clear benefit over chemotherapy. It didn't appear significantly worse, but it didn't appear significantly better. Now, the study wasn't designed or powered to really look at that subset, although clinically that is the subset of interest. And so it is an option for patients, particularly if patients aren't eligible for other therapies. But in this day and age, we have other options that I would say offer a clearly superior benefit to chemotherapy. Strategies such as dual checkpoint blockade or combinations of chemoimmunotherapy. In a world where those options exist, I really think those have a leg up over pembrolizumab monotherapy for PD-L1 low, but it is an option for patients under certain circumstances. IMpower110 was a randomized phase 3 trial looking at single-agent atezolizumab, a PD-L1 antibody, versus histology-specific chemotherapy. This was a relatively large study. Patients were randomized 1-to-1 to receive atezolizumab at a dose of 1,200 milligrams every 3 weeks or histology-specific chemotherapy. And if we look at the PD-L1 high group, looking at PD-L1 expression on tumor cells or on neighboring immune cells, which was about 35 to 40% of the entire population, there's a clear and overwhelming survival benefit. The median overall survival was 20.2 months compared to 13.1. That's an impressive hazard ratio of 0.59 for the PD-L1 high group. 1-year survival rates of 65% versus 50.6%. Response rates were higher, over 38% to about 28%. So outcomes really favoring the use of atezolizumab monotherapy in that PD-L1 high. They also explored outcomes using the DACO22C3 antibody, and the results were very consistent. In patients with PD-L1 high disease, I think atezolizumab is a very reasonable option. It was FDA approved, and I think it is another option for patients. It's not wise to compare it directly to other agents in this setting, such as pembrolizumab. I think those outcomes are very comparable. While there may not be a compelling reason to change, if there were, for example, non-clinical reasons, formulary restrictions that guided one over the other, I really feel comfortable with either approach.